So we are here again with the second lecture of this webinar series, and this time we'll be discussing the basic MRI elbow anatomy. My name is Dr. Stanzin. I'm an assistant professor in radiology at AIIMS, New Delhi.
Welcome, Dr. Stanzin.
Okay, so this will be the outline that we'll follow for the discussion of the anatomy. We'll start with the bones. So it's always a good idea whenever we are trying to look for anatomy, to go from an inside-out approach, so that we know where do the structures lie in relationship to the depth, which is deep and superficial. And secondly, this way we tend not to miss out on looking out for any of the structures. So we'll always follow this inside-out approach. So starting with that, obviously the first thing that we see, one second. So the deepest structure that we'll come across is the bone, and because we're talking about a joint, so the part which is involved in articulation, the articular surface will be lined by cartilage. And since elbow is a synovial joint, it will be lined by hyaline cartilage. And the whole synovial cavity is enclosed with the help of a capsule. So after the articular cartilage, the next layer that we see will be the capsule. So we'll discuss initially just these two overall of the whole elbow. And then to make things more comprehensive and easy to understand and retain, we'll divide the elbow joint into various compartments. And then for each of these compartments, again, then we'll see for a particular structure belonging to that compartment, again, going from the inside out approach. So initially, we'll just talk about the bones. So briefly about the elbow joint, I'm sure everybody knows, but still we'll just quickly revise. So elbow is a composite hinge joint. Hinge joint, that means it will allow movement in only one plane. So elbow joint primarily allows flexion and extension. But it is composed of three different joints, which are formed by three bones. So we can see over here the distal end of humerus, proximal end of radius, and the ulna contribute to the elbow joint, which is composed itself of, again, three joints. That includes the radiocapitellar joint. So this rounded structure is the capitellum. Then we have this is the ulna. So ulna and the trochlea. So ulnotrochlear joint. And there's a third joint as well, which is the radio-ulnar joint. This is the proximal radio-ulnar joint. So all of these three combine together to form the elbow joint. Primarily, like I said, it's hinge joint. So at these two joints, the radiocapitellar and the ulnotrochlear, it allows flexion extension, while the proximal radio-ulnar joint is a type of a pivot type of synovial joint. So it allows flexion and supination and pronation of the forearm. Okay, so we'll just quickly see the important bony landmarks that we need to see, because why is it important to see is that so that on MRI we'll look for these bony landmarks and then indirectly look for the structures, important structures that are attached to it. So the distal end of humerus, we can say that distally it flares out and give rise to these projections known as the epicondyles. On the lateral side, we have the lateral, and medial, we have the medial epicondyle. Here also we can see this is the schematic as seen from front and the back. So medial and the lateral epicondyle. Just above the epicondyle, this area, this is known as the supracondylar ridge, the lateral and the medial supracondylar ridges. Then we have the articular surfaces, that is the capitellum and the trochlea. And inferiorly, we have, this is the radial head, which is cylindrical in shape. And just distal to that, we have this constriction, which is the neck of the radius. And then further distally, we have the radial tuberosity, to which the important structure, that is distal biceps tendon, will attach. Coming to the ulna, we can see the coronoid process anteriorly. Posteriorly, we can see this large olecranon process of the ulna. Then we have the ulnar shaft. Although we do have multiple bony projections, we'll not go into much detail there right now. One more thing to notice over here is that on the anterior as well as the posterior surface of the humerus, we have these concavities. So this one is the radial fossa. and this is the coronoid fossa. Basically, these are concavities which, when the elbow is in flexion, will accommodate the radial head, so the radial fossa, and in flexion state, the coronoid process is accommodated here in the coronoid fossa. And posteriorly also we have a similar concavity, which is known as the olecranon fossa, which in state of extension accommodates the olecranon process. So this is the olecranon fossa. Okay. Okay, now we'll talk about, this is about the bones involved in elbow joint. Then we'll talk about the articular cartilage. So since it's a synovial joint, the articular surfaces will be lined by hyaline cartilage. So in the schematic, the sagittal view of the elbow, we can see this kind of gray lining, thin gray lining over the, this is the trochlea. So this is lining the articular surface, and on the corresponding trochlear notch, which accommodates the trochlea in the olecranon process, it is also lined by hyaline cartilage. And then this structure, which is enclosing the synovial cavity, is nothing but the joint capsule. Okay, so you can see that this is the distal end of the humerus, which kind of gives rise to these concavities, which I showed earlier, anteriorly as well as posteriorly. And these concavities are filled with fibrofatted tissue or fat, and the capsule is deeper to it. So whenever there is effusion, so this synovial cavity will inflate, you can say it will get filled with fluid, and that pushes the capsule further, both anteriorly and posteriorly, and hence these fat pads, that is the olecranon fat pad, the radial or the coronoid fat pad, they will get pushed anteriorly, and that is the reason why we see on a radiograph the positive fat pad sign whenever there is joint effusion. Okay. Besides that, this is just another image showing the lining of the articular cartilage all along the radial head, because the whole of the radial head is involved in joint formation, in articulation. Besides that, this is the trochlear notch, again, which is almost completely lined by this articular cartilage. So it is normal to see that in the mid portion of the trochlear notch, there is no articular cartilage lining. And this structure will be seen on MRI, especially when you look through a sagittal image. You may see the nice articular cartilage lining, but in between, you may see a defect where you don't see the cartilage. Instead, you'll see some fatty tissue, because this space gets filled with fat. So you'll see the fat signal, and sometimes we may confuse it with the loose body. But if we know the normal anatomy, that there is a place in the trochlear notch which is not covered by hyaline cartilage, we will not make that mistake and call it abnormal. So this is also known as the pseudo defect of the trochlea or the ulna. Okay, coming to, we have already seen the capsular attachment. So this is just a schematic showing the lining, along the line along which the articular capsule is attached. Again, we can see the all along the margins of these fossae. Anteriorly, also along the coronoid process, involving the whole head and the neck, a little bit part of the neck of the radius. And posteriorly, again, all along, attachment is seen along the olecranon fossa and the olecranon process as well. So now we'll see the same on an MRI image. Okay, so again, just for the sake of seeing anatomy better, I have taken non-fat suppressed images of MRI. These are PD weighted non-fat suppressed images, because this really helps us to see the structures better. Okay, and even for instability, it's always a good idea to get PD fat sat in all the three planes. So I'm going to the most anterior section. For now, we'll focus only on the bones and the hyaline cartilage that we have just studied about. So we'll see how it looks like, because these are non-fat suppressed images. The marrow fat is not suppressed, that's why it will appear bright. So the bones will appear bright in this scan, and the articular cartilage will not be that bright. It will be kind of intermediate signal intensity, like how you can see over here, and it will be kind of lighter than the surrounding muscle, but still darker than the surrounding bone. Okay, so we'll just look at the bones first. So anteriorly, we start to see this radial head, which is cylindrical shape, and this is the part of the radial neck and the radial tuberosity that we saw in the schematic as well. Radial tuberosity gives rise to attachment of the distal biceps tendon. Then we can see the olecranon process of the ulna. because we are in the anterior portion right now. Then as we go posteriorly, we can see this is the proximal radio-ulnar joint. And the concavity in the ulna, which allows the articulation of the radial head, is known as the sigmoid notch. So this is the sigmoid notch where the radial head fits. And as we go posteriorly, we can see the big olecranon process. And olecranon process, most important attachment that it gives rise to is the triceps tendon attachment. Proximally, for the humerus, again, we'll see the anterior sections. So we can see over here that this is the radial head. Radius articulates with the capitulum. So this is the rounded capitulum. And ulna articulates with the trochlea. So this whole bone is the trochlea. And as we go slightly posteriorly, we can see that again the shaft has flared out to give rise to these prominences. On the lateral aspect, this is radial head, so we know that this is the lateral aspect. So on the lateral aspect, we have the lateral epicondyle, and on the medial aspect, we have the medial epicondyle. Importance of these two epicondyles is that it gives rise to the attachment of one very important thing, that is the common flexor and the common extensor tendons. All right. And okay. And as we go posteriorly, there is one pitfall again, like the trochlear, the capitulum is supposed to appear really smooth like this. But as we go posteriorly, we realize that there's some irregularity in the lateral aspect. And this can be confused with an osteochondral defect. But what it really is that we always have to correlate it with the sagittal image, because as we go and see this section, the sagittal image, which is taken through this part of the radiocapitular joint, we realize that the rounded articular portion of the capitulum is already over. And this is the posterior non-articular portion, which normally also in extension, we see that it lies over the articular portion of the radius. So this should not be labeled as a defect or an osteochondral disease. It is actually a normal appearance of the capitulum at this place. So yeah, you have to correlate. And if we had seen the similar appearance in the anterior portion of the capitulum, then it is abnormal, because the usual osteochondral disease of the capitulum that we see is commonly seen in the anterolateral aspect. Besides that, on a fat suppressed image within the bones, you have to look for edema patterns. For example, the medial and the lateral epicondyle can be involved in disease process, of course, and sometimes when the medial and the lateral epicondylitis are very severe, then it can lead to changes in the bone as well. Although primarily it is the chronic overuse disease of the tendons, but yeah, later stage it can lead to changes in the bone itself. Okay, so this was about the bone, and now I'll just quickly show the articular lining. So for articular cartilage, better visualization, we usually do GRE sequences like this, where rest of the bone will just appear hypo and we'll not be able to see if there's any edema or any abnormality. This is predominantly done only to look for the cartilage. So as we go from, so yeah, we'll just keep another image also. So we can see that this is the round radial head and this is the ulna. So we are going from the lateral to medial aspect. So as we go from lateral to medial, we can see that this nice bright structure, this is the hyaline cartilage lining the radial head, and this again is lining the capitulum as well. And the articular surface of the capitulum ends here. So that's why I was saying that in the coronal image taken at this level, it may look like an abnormality, but it's not actually the same. Okay, so as we go posteriorly, we just have to make sure and see that the articular cartilage lining is all around the capitulum, all around the radius. And as we go further laterally, we can see it surrounding all around the trochlear process as well, and along the trochlear notch of the ulna. And at some places, how I had shown in the schematic that there may be some places which may not be lined with the articular cartilage. It will look something like this. So it may look like, okay, there is nice articular cartilage lining here and in the anterior aspect also, but suddenly there is a defect here. So this is not abnormal. This is a normal variant, and this is a typical location for it. So yeah, if you have enough knowledge about the normal anatomy, then you will not label it erroneously as abnormal. Okay, so we scan through the whole articular cartilage lining and it appears normal. Okay, now we'll move on. So we have discussed the bones, we've discussed the articular cartilage lining as well. So we'll move on to the next layer. So we are going from inside out. We've seen the innermost, then we've seen the lining. Then now coming to the capsule. Capsule is usually, unless it's abnormal, it's very thin. So it's difficult to visualize in a like normal MRI. But just as a mechanism, protective mechanism, at some places, the capsule is focally thickened, and which gives rise to those ligaments in the medial lateral aspects. And that's what we study about. Okay, so after that, this we have discussed. So now we'll divide the further discussion about the ligaments and the surrounding muscles and the neurovascular bundle into different compartments for it being very, just to make it more comprehensive. So we'll start with the anterior compartment. So anterior compartment, most important structure that we need to study in anterior compartment is nothing but the biceps tendon. And then we'll go to the lateral compartment, the medial and the lateral and the posterior compartment. So starting with the anterior compartment, if we talk about ligaments, like I said, ligaments are nothing but reinforcements of the capsule itself, and in places where it's where the capsule is exposed to greater stress, it gets thickened just to keep it protected. So in the anterior compartment, there is no such ligament per se. So we'll move on to the next layer. So within a joint, after articular cartilage and the capsule, next layer is layer that we see is of muscles. So in the anterior compartment, we'll now discuss the muscles. And the most important muscle, like I said, is the distal biceps tendon. Besides that, anteriorly, we also see the brachialis muscle. Okay, quickly, few words about biceps tendon. As the name suggests, biceps. So it will have two heads, the long head and the short head. Long head, we study a lot about it in the shoulder, that it goes all around the humeral head in the bicipital groove, followed by superior aspect of the humeral head, and then attaches to the supraglenotubercle, and the short head attaches to the coracoid process. And all along, we always study about the biceps tendon being, distal biceps tendon being a single structure, but actually what is seen is that these two never completely unite. So even in the distal aspect, we may be able to tell the two heads separately. So the long head is usually laterally located, like here also we can see, and the short head is medially located. And even in the distal aspect, this is the musculotendinous junction. We can see that this is the long head, which remains lateral. And as we go down distally, so we remember that biceps tendon attaches to the radial tuberosity. This is something which almost everybody knows. So at the radial tuberosity also, the long head attaches slightly proximally, and the short head attaches slightly distally. And we have one more structure in the distal biceps tendon. There's a fibrous expansion arising from this musculotendinous junction, and it moves medially. So we know that it attaches to a lateral structure, but there is another fibrotic expansion which goes from the tendon to the opposite direction, that is ulnar side. And this expansion goes laterally and blends with the deep fascia overlying these ulnar muscles or the flexor muscles. Okay, so this is about the basic anatomy. And the other important muscle that we see in anterior compartment is the brachialis. So we can see over here in the schematic that the brachialis is quite a muscular muscle, and predominantly it remains muscular, and just in its most distal few centimeters, it turns completely tendinous, and it attaches to the ulnar tuberosity. So biceps attaches to radial tuberosity, brachialis attaches to the ulnar tuberosity. So now we'll see the same on the MRI. So it's easy to identify the biceps tendon and the brachialis on an axial image. So if we see an axial image at the level of the elbow, you'll see that there's a huge muscle bulk just in front of the bone. That is always the brachialis, and this is the way to identify it. So it's huge at this time. And at the level of the elbow, the biceps has already turned tendinous. So if the structure, tendinous structure seen just anterior to this big muscle is nothing but the distal biceps tendon, and the tendons will appear purely hypodense like this, hypointense. So, and you can easily tell that there are two bulbous structure rather than a single structure. So this is nothing but the long and the short head of the biceps. So what we can do is that we can look for this tendon. I'm going distally, and we can see that it is going, it turns slightly, almost like a 90-degree, turns deep, and then we follow it, and it goes further to attach to the, this is the radius and this is the ulna. So inferiorly it goes and attaches to the radial tuberosity. So this is the attachment site of the radius. And we just have to follow it and see that there's no tear or any discontinuity. Similarly, we can follow the brachialis also. I'm again going proximally. So like I said, this at the level of the elbow, the big muscle that we see is the brachialis. So as I trace it inferiorly, it's still muscular majorly, and its tendon is seen in the middle. And as I go further down, we can see that now it is only tendinous. The muscle has ended. And immediately after that, it attaches to the ulnar tuberosity like this. So this is about the anterior compartment. One more thing that I showed in the schematic as well, the Lasseter fibrosis or the bicipital aponeurosis. There's a fibrous expansion, like I said, which arises from the distal musculotendinous portion of the biceps. So this is the biceps tendon, which is seen very superficially. You can see that there is skin, subcutaneous tissue, and just immediately deep to that, we see the biceps tendon. So we identify the biceps tendon, and then we look for a dark, thin, fibrous structure extending from the biceps and going medially. This is the medial aspect. Okay, so you can see that this dark band is going this side as I go slightly inferiorly, and then it has finally merged with the fascia overlying these muscles, and these are nothing but the flexor group of muscles, flexor or the medial aspect. So this is the pronator teres. So you can see that the fascia, that the fibrous band that extended from the biceps tendon has merged or blended with the deep fascia overlying this muscle, that is the pronator teres. So this is nothing but the bicipital aponeurosis. Significance of this, of identifying the integrity of bicipital aponeurosis is that if suppose there's a complete tear of the biceps tendon, but the aponeurosis is still intact, then even with complete tear, the retraction may not be visible. So it's important to see whether this is intact or not, along with the biceps tendon. Okay. So other important anterior structures include the neurovascular bundle. So one mnemonic one can remember for the relationship is BAM or BAM. B, obviously, for the most important structure that we see here, that is the biceps tendon. Then we see the artery, that is the brachial artery, and M stands for the median nerve. So the important nerve in the anterior compartment is the median nerve, and nerve looks like this on MRI. Because the nerve has multiple long fascicles which appear completely hypointense, like how we're seeing here, round things. And there's some interspersed hyperintensity, which is nothing but the perineural or the within the nerve, there is some fat tissue. So these are the fat, and these round things are the fascicles. So this is the median nerve. So yeah, this is how you can identify it. The look for the tendon, then the artery, and then just medial to that, you'll find the median nerve. So median nerve injuries and involvement, you can just trace the median nerve all along its course. Mostly what happens is at the level of the elbow, the median nerve will be one in relationship to the biceps tendon and the brachial artery, and it is medial to the brachial artery. And as we go down, we can see the nerve here. We're going distally, And now it is going deep to the pronator teres muscle. This is the pronator teres, and the nerve is here. It's difficult to see when it is in a slightly oblique orientation. But as we go down, the nerve is still here, and this is the humeral head of the pronator teres. This is the ulnar head. So the nerve goes inferiorly in the forearm between the two heads of the pronator teres. And this is one of the common sites for entrapments leading to median nerve entrapment, besides the obvious common site, that is the carpal tunnel. So this is also one side, and involvement of the nerve here can lead to pronator teres syndrome. Okay, so we have completed the anterior compartment. Then let's move on to the lateral compartment. So lateral compartment, again, we'll discuss the ligaments here, then the muscles around it, like that. So again, in this schematic, we can see this is the radial head, this is the ulna, this is the end of the humerus with the lateral epicondyle and the capitulum. So we'll talk about this lateral compartment and the lateral ligamentous group. So lateral ligamentous group consists of 3 ligaments. Obviously, the name, you can imagine with the name, we're talking about the radial aspect. So a radial collateral ligament will be seen. And again, no price guessing that it would attach the lateral epicondyle to the radial head. So that is the typical radial collateral ligament or the lateral collateral ligament that we would expect. Okay. And here in this image, we can see this is the lateral epicondyle and this is the radial head. So we can see this green band which is extending from the lateral epicondyle to the radial head. That is the lateral collateral ligament, and this is in the anterior aspect. But there's one more ligament with a confusing name called the lateral ulnar collateral ligament. It sounds like there's ulna in it, so it should be some medial structure, but it's not. It is again a radial collateral ligament component, you can say. So this is why is it named such, is because it has its attachment proximally at the same site as the radial collateral ligament, that is from the lateral epicondyle, but inferiorly it goes medially, like it goes posteriorly, laterally, and then finally to go and attach to the supinator crest of the ulna. That's why the ulnar component of the lateral ulnar collateral ligament. So proximally it shares almost the same site of origin or attachment as the lateral collateral ligament, but distally, instead of attaching to the radius, it attaches to the ulna, and hence it's called as lateral ulnar collateral ligament. So significance of radial collateral ligament is that it is the primary restraint to varus stress. Yeah, this is the primary restraint to the varus stress, and a lateral ulnar collateral ligament, because now you can see that it's something that goes posteriorly and laterally to attach to a medial structure. It will prevent instability or abnormality in the posterolateral aspect. So LUCL is an important restraint to the posterolateral rotatory instability. So the third component of lateral ligamentous complex is the annular ligament. Annular, as the name suggests, some ring-like structure. So it is just a ligament which surrounds, completely encircles the radial head. And because we know that the radial head attaches to the articulates with the ulna through the sigmoid notch. So this lateral annular ligament will also attach to the margins of this sigmoid notch. So, and it completely encircles the radial head. It prevents the subluxation or dislocation of the proximal radioulnar joint. So again, annular ligament also gives attachment to the radial collateral ligament. I mean, this blends with the annular ligament. And yeah, now we'll see. And one more important thing to remember is that the lateral epicondyle is the site of attachment for the lateral ligaments, but just superficial to that, okay, just above that is also the site for attachment of the common extensor origin. So all of these structures will be sharing a very close proximity with each other, because the origin of the common extensor is right here, and just below that is the origin for the lateral collateral ligament and lateral ulnar collateral ligament. So they will kind of blend, and many times we may not be able to really see and show them separately because they're so closely opposed. Unless there is a lot of effusion, there's some injury to one of the components. Anyway, so let's try to identify them now. Again, this is the coronal image, this is the axial image. So these ligaments, obviously the lateral, the collaterals are best seen in coronal image. Just like in the knee, we look for those medial and lateral collateral in the coronal image, right? But we should also correlate it in the axial. So this is the anterior part. So if I go more anterior, and then now I'm going slowly posteriorly, we can see the radial head. I want to look for the side where I see the almost start to see the lateral epicondyle, giving rise to attachment of these ligaments. So ligaments as well as the common extensor tendons will both appear completely dark, or T1 or T2, all sequences, it will appear hypointense. So now we can see that there is a band which is extending from the inferior surface of the epicondyle and going and attaching to the radial head annular ligament. So annular ligament not separately well seen, but you can see a band extending from this to this area. This is nothing but the radial collateral ligament. Excuse me. So in the anterior aspect, you'll see the radial collateral ligament. And now if I just scroll a little bit posteriorly, you can see that there is more, there are few more fibers, again coming from the inferior part of the lateral epicondyle and merging with the annular ligament. So this is still part of the radial collateral ligament. And as I go posteriorly, we'll see again arising from here, we'll see some dark band going through the annular ligament. And now we're seeing that posterior to the radius, something is going inferiorly like this. And in one more section, if I scroll further, we can see that it's going, and this is the ulna, and this is the posterior aspect of the ulna. There's something which is attaching to the posterior aspect or the supinator crest of the ulna, that is nothing but the lateral ulnar collateral ligament. It's very difficult to visualize it, especially on a coronal image like this, and unless it's injured, it's difficult to see. But yeah, some way you can just imagine a band going like this, because it is not within one single plane. That's why it's difficult to identify. So you can try and see it in the axial image. This is the level of the radial head. So this is a sigmoid notch, the anterior and the posterior margin. And we can see that something is attached, thin band is attaching to the posterior margin of the sigmoid notch. That will be the annular ligament, because annular ligament encircles this radial head like this. But as we go inferiorly, this is a supinator crest. This is the radius, this is the ulna. Ulna has a medial, actually a lateral projection from its proximal shaft like this, which is known as the supinator crest. And we can see that there's some thin band attaching to it. And you can trace it proximally and see that it merges with the common extensor. So that is the lateral ulnar collateral ligament. And of course, the most prominent structure that we see on this side is nothing but the common extensor tendon. That is, this is the upper superior part of the lateral epicondyle. So you see this dark structure coming down, thick band. Okay, this whole thing is nothing but the common extensor tendon. So on the axial also, if we try to see, this is from this whole thick band is the common extensor tendon. But as we go slightly inferiorly, yeah, so this is the common extensor, and deep to that we see some other structures. So these are the lateral ligamentous complex. So always remember that the ligaments will be deeper and the common tendons will be superficial. Okay, so yeah, this is how we see the lateral ligaments. And it's always a good idea to see these on a sagittal image as well, just because we can see over here that the lateral common extensor tendon has a very broad anterior-posterior attachment. So the same can be seen on a sagittal image. So this is a section. This is taken through the common extensor, and we can see over here this whole thick dark band is nothing but the common extensor tendon. And if there is injury, it's very easy on a sagittal image to say that the anterior part, the middle part, or the posterior part of the common extensor is involved in the disease process. Okay, So radial side ligaments we have discussed. We have discussed the muscles. So radial, the most prominent muscle that we'll see in the region of the elbow is nothing but the brachioradialis. So in the forearm, the brachioradialis is considered a component of the posterior group or the dorsal compartment muscle. But at the level of the elbow, it will be seen on the lateral, and in fact, even lower down, it is predominantly in the lateral aspect only. Okay. And yeah, now the neurovascular bundle structures that we see on the radial aspect is obviously the radial nerve. So the way to identify the radial nerve on a MR image is again bring the section to a level at the elbow and identify that this big muscle is the brachialis and this is the radial aspect. So the radial aspect, whatever big muscle that we see, is always the brachioradialis. And the facial plane between the brachialis and brachioradialis is where we find the radial nerve. So again, like I said, these nerves are small nerves, and they have these fascicles and fat around it. So they will just be seen as these round, dark, round structures. So this is the radial nerve between the brachialis and the brachioradialis. And we can trace it inferiorly. Oh, I'm going superiorly. If we trace it inferiorly, yeah, this is still the part of the nerve. And now we can see it divide into a superficial and a deep branch. And the deep branch is going directing posteriorly and posteriorly going further. And we can see that there is a thin slip anteriorly and posteriorly. This muscle is nothing but the supinator muscle, and this is the radial head and neck region, which so supinator muscle is seen all around the radial proximal radius. So which has two heads again, ulnar radial head and a humeral head. So this is one head, this is another head, and we saw that the radial nerve is here, and as we go inferiorly, it goes between these two heads. So this facial plane between the two heads of the supinator is also known as the supinator tunnel, in which the deep branch of the radial nerve enters and becomes the posterior interosseous nerve. And this is again a common site for entrapment of the radial nerve. Okay, so that's where we look for the radial nerve, any abrupt change in the caliber of the nerve, or if there is abnormal signal within it. So here it looks pretty good. I mean, the nerve is looking okay in this patient. Okay. Then I guess that is all about the lateral. One more muscle that we see in the lateral compartment, or more of a posterior compartment, is the enconius muscle. Enconius muscle is seen just radial to this ulnar, radial to this ulna, or just posterior to the radial head. So this muscle here is the enconius muscle. Okay, so this is about the radial aspect. Muscles we have seen, and the radial nerve, PIN. Okay, this is just a schematic which shows this is the two heads of the supinator muscle. One head is here, one head over here, and between the two heads is the supinator tunnel. It's where the radial nerve enters, and this side where it just enters the supinator tunnel, there is a bit of a facial thickening, and that is known as the arcade of Frosch. And this is the site which is considered one of the commonest sites for radial nerve entrapment. Okay, moving to the medial compartment. So coming to the ligaments of the medial compartment, on the radial side, we had a radial collateral ligament. So obviously on the ulnar side, we'll have an ulnar collateral or the medial collateral ligament. So if you see the schematic for the medial collateral ligament, again, medial, so medial epicondyles. It will arise from the medial epicondyle. And now it will attach to obviously the ulna, right? Because we're talking about medial structures. So what part of ulna? We have seen the coronoid process of the ulna. The most medial part of the coronoid process is also known as the sublime tubercle. So this ligament will arise from the medial epicondyle and attach to the sublime tubercle of the ulna. So medial collateral ligament has got three bands. It is this anterior band which attaches to the sublime tubercle that is the most important and the strongest of the three bands. And this is again an important restraint to valgus injury. Yeah, so valgus stress. This is the anterior band. Then we have this broad fan-shaped posterior band of the ulnar collateral ligament, and then there's a transverse band. But on MRI, we usually get to see majorly this anterior band and the posterior band, and the transverse is not seen, and we don't really need to evaluate it, just not of much significance. This is just in comparison to medial collateral ligament. I've tried to show the radial aspect. So again, on the radial aspect, like we have studied, we have this annular ligament all around the radial head, and the radial collateral ligament, which extends from the lateral epicondyle to the annular ligament or the radial head. Then we have a lateral ulnar collateral ligament. So radial collateral ligament doesn't have many parts to it, but we have another ligament called lateral ulnar collateral ligament. But on the medial aspect, we have the medial collateral ligament, which has an anterior and a posterior band. So either way, we see that this green thing is the capsule. So these ligaments are just reinforcing the capsule at these areas, which will be under stress, just to avoid any sort of instability. Okay. And then, of course, one more thing, just above this, superficial to the ligaments, we see the muscles. So obviously the common extensor tendon, common flexor tendon, sorry, on the medial aspect will be superficial to this ligament. So it will take its origin from the medial epicondyle, but from slightly superior aspect. And yeah, okay, first we'll see these ligaments and then we'll come back to the muscles. And like I said, for collateral ligaments, coronal is the image to see. So if I see slightly anteriorly, so this is the coronoid process of the ulna. And as I go slightly posteriorly, we'll see this projection of the coronoid process known as the sublime tubercle. And we can see there is a thick band extending from the sublime tubercle, going all the way to the medial epicondyle. So this big thing is the medial epicondyle, and this band is extending from the sublime tubercle to the medial epicondyle. This is nothing but the anterior band of the medial collateral ligament. So the posterior band is seen on coronal like this, but it's better seen on the axial image. And where do we look for it? It's very simple. We just have to look for the cubital tunnel. And everybody knows the anatomy of cubital tunnel. It is something, it's a fibrosis tunnel which lies between the olecranon and the medial epicondyle. So yeah, just look for the medial epicondyle, look for the olecranon, and then you should see something attaching, or attaching these two. So this is nothing but the roof of the cubital tunnel. Okay, this retinaculum-like structure, which is also known as the Osborne's ligament. This will cover this cubital tunnel and make it a fibrous tunnel. Okay, so this is the Osborne's ligament. So we have to look for what is there in the floor of the cubital tunnel. So you see this band which is nicely lying in the floor. This is the roof, and this is the floor of the cubital tunnel. So the floor of the cubital tunnel is formed by nothing but the posterior band of the ulnar collateral ligament. That's all you have to remember, and this is where you identify it. So posterior band of ulnar collateral ligament, floor of the cubital tunnel, and yeah, that is it. And okay, now that we've talked about the cubital tunnel, so bony, you already know, the roof is the Osborne ligament. Some people say this Osborne ligament is nothing but the extension of the fascia between the flexor carpi ulnaris two heads, which has gone all the way up here. So either way, we'll just see it as a thin band on MRI. So the content of this fibrous tunnel, the cubital tunnel, is ulnar nerve and just some fibrofatty tissue. So you should not see anything else other than that. If you start seeing some other content, that will cause this closed tunnel to, because there's limited space already, and it is limited by these fibrous bands. So if there's any other structure that is there other than the normal contents, that was going to cause entrapment or compression of the ulnar nerve. So we should look for any osteophytes coming out of this. This is the olecranon, this is the trochlea. This is the trochlea and the olecranon of the ulna. Ulnotrochlear joint osteophytes may project into this space. Sometimes they may be really big and can cause impingement of the ulnar nerve, one, and sometimes there can be synovial fluid projection into this space. Again, that can be a cause of ulnar nerve impingement as well. So we just have to make sure every time we see the cubital tunnel that there should be only ulnar nerve. This is the ulnar nerve, by the way, ulnar nerve and some fatty tissue and nothing else. Okay, and one more thing that we must see is that this big bony projection is the medial epicondyle. and the ulnar nerve always lies posterior to it within this tunnel. So if you don't see any ulnar nerve here, that means then we have to search for it somewhere else. It may be seen in the subcutaneous plane or anteriorly. Again, due to maybe rupture of this osborn ligament because of the ulnar nerve subluxation or dislocation. So we have to look for that as well in the medial aspect. Okay. We have already seen the medial and the lateral collateral ligaments. We've seen the ulnar nerve, and about coming to talk about the muscles. Most important muscle that we see at the elbow level on the medial aspect is nothing but the pronator teres. And why again pronator teres is so important is because it forms important relationship with the one nerve, that is median nerve. So again, elbow level, this big muscle just in front of the bone is always the brachialis, and between the brachialis and the brachialis and the pronator teres on the medial aspect, we'll identify or we'll is a landmark to look for the median nerve. So this is the brachialis, pronator teres. We see the median nerve here. Okay, and of course the flexor muscles will be around. So this is it about the medial compartment. So coming finally to the posterior compartment. The major component of posterior compartment is this big, huge muscle, that is the triceps muscle. Triceps has 3 heads, as the name suggests. It has a long head which arises from the infraglenoid tubercle, the lateral head from the humeral shaft proximal, and medial head also arising from the shaft. So what happens is that the long head and the lateral head fuses together to form a broad tendon, a thick tendon, which attaches to the olecranon process. While the medial head, it does give, contribution to this thick broad tendon, but mostly it remains muscular and it attaches to the olecranon anterior to this tendinous structure. Okay. Besides that, there's one more muscle in the posterior compartment, which some people study in the lateral compartment also. Either way, this muscle, which is nothing but the enconeus muscle, seen just posterior to this radius and just radial to the ulna. Some people, there have been some have hypothesized that it's nothing but an extension of the triceps muscle. But either way, we do get to see this muscle separately. So, yeah, posterior compartment muscle is best seen in a sagittal view. Okay, so it's very easy to identify also because we can see this is the olecranon process, and we can see this thick, very thick dark band tissue attaching to the bone here. So this is nothing but the triceps tendon, which is attaching to the olecranon, and this predominantly gets contribution from the long head and the lateral head. The medial head, on the other hand, you can see it is still very muscular all the way to its attachment to the olecranon. So it remains as a muscle, and the other two as tendons and attaches here. Okay, and one more thing in the posterior compartment that we need to see is this olecranon fossa, which has nicely accommodated this olecranon process, but also we can see the fat which is filled normally in the olecranon process, olecranon fossa, which suppose if there is a effusion, then the synovial lining, like we saw earlier, it's all along here, all along the olecranon, not synovial, the capsular attachment, all along this olecranon. So what will happen? It will get filled with fluid, the capsule will get displaced posteriorly, and pushing this fat further posteriorly, giving rise to the fat pad sign on lateral X-ray. Okay. Yes, that's it then. Ligaments. Okay, we've already seen the ulnar collateral ligament. Okay, and that is it. We've covered all the anatomy. Hello? Hello, is anybody here?
Hello.
Hello, yes, sir.
Yeah. Thank you, madam, for the nice presentation.
Mm-hmm.
And we got through all the anatomy, revised, and it was very thankful to that you participated in our program. And we're looking forward to have such program in the future also.
Okay, thank you, sir. Thank you for having me.
Thank you. Okay.
Okay.
Bye, madam.
Okay, sir. Goodbye.
Okay, bye. बोलो।
ये पट्टी कटवा दे।
क्या चीज? नहीं, पट्टी खाली दिखना, घाव नहीं ना है।
नहीं,
बांध लो उसको, जाओ
बांध दे। और उधर रिपोर्ट करवा दिए।
रिपोर्ट करा, घर जाओ ना, रिपोर्ट आएगा तो भर्ती
दवाई
करना। हाँ,
सब
दवाई लिख, सर से लिखवा लो दवाई लिख दो, इसका कागज दीजिए। घाव देख लो ना इसका कैसा है। उसने एंटीबायोटिक सर दिए थे, बोला खोल दिया।
पट्टी खोल दिया, फिर उसका बंद लगा भी रहा।
देख लो
सर क्या हुआ? हाँ, नॉन रिलीफ तो दिया कितना सर?
दवा, वही दवा चलेगा ना, सुई छोड़ के बाकी सब दे दो।
भर्ती करना है अभी नहीं, जब जांच आएगा तो ऑपरेशन बेटा। कल रिपोर्ट देगा बाहर आएगा।
पहले हमको रिपोर्ट दिखा, फिर टाइम देना, ठीक है? कितना दिन, 5 दिन हो गया है?
7 दिन
रिपोर्ट दिखा के सुबह मतलब रिपोर्ट आएगा तो कहाँ रहता है?
लोग
एक बार रिपोर्ट दिखा दो ना।
रिपोर्ट तो भी बोला शाम को देंगे।
कल सुबह तुम आके एक आदमी बोले रिपोर्ट हमको 10 बजे खबर कर दो, होगा तो कल सुबह खाना खा लेगा, दोपहर के बाद नहीं खाएगा, शाम को कर देंगे। अगर करना हो रेडी करना, सामान मंगाना पड़ता है ना। कल मान लो कैसा, हाँ कल कैसा है, कल होगा तो कल कर रही होगा, परसों तो होगा ही होगा। हाँ ले लो। आइए क्या है? किसका है ये?
पिछले बार करवाया था।
ठीक है, प्लास्टर करा लीजिए। ठीक है, ऑपरेशन का जरूरत नहीं, प्लास्टर में हो जाएगा। चलो कागज दीजिए, बोलो पक्का कर देंगे। है 7. दर्द तो खत्म हो गया ना। ठीक, 500 जमा करना है इसका। अंदर ले लीजिए, पक्का कर देगा। हाँ, अब प्लास्टर कटेगा, आपको 1 तारीख है तो अगला 15 कट जाएगा। जी। क्या नाम? उमर क्या हुआ?
ये हाथ में ना इसमें 1-1.5 महीने से दर्द हो रखा है। तो पहले तो बीच में थोड़ा कम दर्द था। हाँ जी, इस नस में और अभी स्वेलिंग भी आ रहा था। और 2-4 दिन से ना पूरे हाथ में दर्द हो रखा है। कभी कहीं दर्द होता है, कभी कहीं प्रेशर नहीं लगा सकते। नहीं यहाँ ये पोर्शन में ज्यादा दर्द हुआ है और प्रेशर वगैरह नहीं रहा, प्रेशर नहीं लगा पाती ज्यादा। 2-3 दिन से तो बहुत दिक्कत हो रहा है।
ऐसे कुछ बढ़ाने का नहीं है, मालिश नहीं कीजिएगा, बर्फ लगाइएगा। जो भारी सामान उठाएं सब पेन हो।
लेकिन बहुत दिन से ये पेन जा ही नहीं रहा, इतना बार मुंह वगैरह सब कुछ लगा दिया, लेकिन फिर भी ये ठीक नहीं हो रहा है।
चल जाएगा। ये बैंडेज आपके पास? ये बैंडेज इनमें लगा के दीजिए आँख का, है ना। और मालिश वगैरह नहीं,
मालिश वगैरह तो किया भी नहीं।
मुंह मत लगाइए, मुंह भी नहीं लगाना है।
बैंडेज से भी क्या
बैठ जाओ। हम लोग कुछ चले जाएंगे सर यहाँ से साइड से। लेडीज आप लोग सर
हाँ इसको ना तो छोड़ दो, इसका तुरंत जांच कर होगा और सूजन घटेगा तो ऑपरेशन इसका
सर इसको सर भविष्य में उस तरह के सब कुछ पहलुआं सर कभी पैर में मोड़ने को तकलीफ तो नहीं होगी सर।
देखो जोड़ में 3 हड्डी टूटा है तो बढ़िया से जुड़ जाएगा तो पैर उड़ेगा, जोड़ जाम है तो है ही नहीं। तो जो 3 हड्डी होता है यहाँ 1 2 तीनों टूट गया, टूट गया, ये भी टूट गया, ये भी टूट गया, ये भी टूट गया, ये भी नहीं। जाम होगा कि नहीं होगा, ये बढ़िया से करो तो जाम कम होगा।
बढ़िया से जाम मतलब क्लियर
अच्छा से ऑपरेशन करने से कम जाम होगा।
जी सर इसीलिए
जाम का डर तो रहेगा ना भैया।
जी सर इसीलिए हम लोग अपना दूर सर आए सर, वहाँ पे एक वहीं पे डॉक्टर साहब बोल रहे थे कि हम वहीं कर देंगे, हम लोग को भरोसा नहीं था पहले हम लोग वहाँ पे नहीं करेंगे, इसलिए हम लोग
नहीं बढ़िया से करेंगे, अच्छा से करेंगे,
सर हम
कोशिश करेंगे पैर पूरा मुड़ जाए। जाम होने का डर है, पैर 3 जगह टूटा है ना और जॉइंट में टूट गया।
जाम तो नहीं होगा होगा तो
अब भविष्य क्या बताएगा, तो इसकी डॉक्टर के हाथ में है नहीं, डॉक्टर तो बढ़िया से इसको सब फिट करेगा तो जल्दी से पाँव मुड़वाएगा नहीं।
सर खर्चा वगैरह कहाँ पे सर?
खर्चा 3 ऑपरेशन है तो मान के चलो कि 50-60 मान के चलो, 50-60 मान के चलो, 50 से 60 मान के चलो। हाँ सब 10-15-20 जाएगा ऑपरेशन, 20 जाएगा लोहा दवाई और 8-10 जाएगा रहने का, 50 से 60 मान के चलो। हाँ ये तो भगवान ने बताया, हम लोग डॉक्टर बढ़िया से मेहनत करता है, डॉक्टर का बजट नहीं रहता। हाँ ये तो जान
तो निश्चित रूप से करेंगे सर,
करना ही पड़ेगा ना।
जो पहले उसको पीछे से बता दीजिएगा ताकि उसको रूप हल करेगा सर।
वो तो बाद का बात है बाबू, पहले तो हड्डी जोड़ना है, बाद में व्यायाम होगा, क्या होगा। चल एक लेके आना इसको। ये दुकान से लेके आओ ना, ये दुकान से लेके आ जाओ। सर को दुकान से लेके सर को चाहिए, अरे बाबा बढ़िया से करेंगे तुम। पैसा से तो इलाज नहीं खरीदा जा सकता है ना। बात खत्म हो। रिजल्ट तुम्हारा हाथ में ना मेरा हाथ में, भगवान का हाथ में। तब बढ़िया से काम करो, जो जरूरत है करना जरूरी उसको है। हाँ हम लोग कोशिश करेंगे काम मुड़ जाए, लेकिन जाम होने का डर है, मान के चलो। सब डॉक्टर ही तुमको बोलेगा नहीं, फिर होता है ना अलग चीज। यहाँ बीच में टूटता तो बात नहीं था, यहाँ टूटता तो बात नहीं था, यहाँ टूटता तो बात घंटे में टूट गया। तो घंटे जाम होता है। एक कोशिश करेंगे जॉइंट कम से कम। सबका थोड़ी जाम होता है, 100 में 2-5% का जाम होता है। ये बोलना तो पड़ता है ना। डॉक्टर नहीं साहब बोलेगा तो बोले डॉक्टर साहब को बोला नहीं, झूठ बोल के हमको ऑपरेशन करा दिया। बोला पाँव मुड़ेगा। मेरा बात सुनो ना, डॉक्टर क्या बोलता है? बोला कि नहीं डॉक्टर पहले बताया नहीं पाँव मुड़ेगा। बोला पूरा मुड़ेगा तो मेरा पाँव मेरा। झूठ बोल के ऑपरेशन करा दिया हमारा। जो उम्मीद करेंगे नहीं होगा। चलिए उसमें बहस करने का फायदा कोई नहीं, ऑपरेशन बढ़िया से करना है, मुड़ना तो अलग चीज है। चलिए बोलिए, दिन भर कंसल्टेशन होते रहता है ये। बोलिए। हाँ हाँ तो वजन जरा खोल दीजिए। हाँ दे दीजिए, एक गोली दे दीजिए रात में। नहीं तो एक गोली और दो गोली दे सकते हैं। थोड़ा सा थोड़ा ढीला कर दीजिए वजन को, और एक गोली खिला दीजिए। और नहीं हो तो गोली रात में और दे दीजिएगा। 2 गोली भी खाने से कुछ नहीं होता है। तो सही है ना सावला, सही है ऑलरेडी नहीं उसका पास नींद नहीं आता है। अच्छा हम दूसरा दे रहे हैं, चलिए हम दे रहे हैं यहाँ से। अच्छा काट के दूसरा कर दे। चार्ट को ले आप शूट करेगा तो यही वाला चल रहा है, ये वाला बंद कर देना, ये वाला भी नींद का है, हल्का है वो।
आज हो गया 5वां दिन एडमिट करने में, लेटरिन नहीं हुआ उनको।
अच्छा, तो लेटरिन का दवा ले आकर 2 समय रात में लेगा। ये दोनों ले आते हमको चाहिए। आइए, किसका?
अभी मैं आया बाहर में सर,
क्रैक नजर आ रहा है, देखिए कहाँ पे?